we have Dr. Elie Naddaf with us. He's a neurologist at the Mayo Clinic in Rochester. And his special interest is peripheral neuropathies and myopathies associated with systemic diseases, also hereditary and autoimmune neuromuscular diseases. And he will talk about paraproteinemic neuropathies. Elie, please.
Thank you, Dr. Kotnik, and thank you for the invitation. Let me just share my slides. So the pathology photo you see here on the first slide is actually onion bulb skinning in a patient with Castleman's disease, but I will not be covering Castleman disease today because of the sake of time, but it also looks like a light at the end of the tunnel. So hopefully we get through this pandemic and go back to in-person meetings. I have, these are my financial disclosures, but nothing related to today's talk. And hopefully by the end of the talk, you will be able to identify when and how to screen for underlying plasma cell disorders and determine the relationship between a detected monoclonal protein and peripheral neuropathy. So it will be more an approach to these patients rather than a detailed description of each type of paraproteinemic neuropathies. So let's start with the introduction to plasma cell dyscrasias. Paraproteinemic neuropathy indicates there is a paraprotein or a monoclonal protein secreted by a plasma cell that's causing or associated with the neuropathy. So plasma cell, as you see in this photo, this is actually a biopsy from a patient with Sjogren neuropathy. The plasma cells are characterized by their eccentric nucleus and abundant cytoplasm. And they have quite a distinctive function of secreting immunoglobulin or monoclonal protein. And the relationship between a monoclonal protein and the neurological disorder can be of different types. It's very, very rare, a zebra, for a neurological disorder to cause a hematologic complication, such as certain inherited myopathy that they can be associated with anemia or neutropenia. It's a little bit more common for both the hematologic and the neurologic condition to be caused by a third condition, such as vitamin B12 deficiency, causing a neuropathy or myelopathy and anemia. But it's way, way more common for hematologic disorders, and in particular, plasma cell dyscrasias, to cause neuromuscular complications. And they can cause such complications via different mechanisms. The complication can be due to abnormal cell proliferation, which is a little bit less common in myelomas and more common in lymphoma that invade tissue. It can be related to the secretion of the protein and the position of these proteins, such as can be seen in amyloidosis. They can also cause a paraneoplastic disorder where the hematologic cancer is triggering an immune response, as can be seen in Bowen syndrome. Also, they can be related to systemic complication of these hematologic disorder, mainly, for instance, hypercoagulable state with central nervous system complications. And also, and most importantly, they can be treatment-induced. Almost all treatment that are targeting plasma cells or myeloma cause neuropathy. So as you can see, it can be a challenging situation to determine the relationship between a monoclonal protein and a neuropathy in a particular patient. But what's a monoclonal protein? We keep saying monoclonal protein. So the photo here to the left, it's under normal circumstances. Our immune system has so many different plasma cells secreting various types of immunoglobulins. So if you put the serum of this patient on a gel and you electrophorese it, you see a wide-based curve in the gamma range. For unknown reason or under certain circumstances, one plasma cell proliferate. And as all these cells come from the same original plasma cell, they all secrete the same protein. So they are a clone of cells secreting the same protein, and that's what's called a monoclonal protein. So now if you put the serum of this patient on a gel on top of the wide-based curve, you see another spike there, and that's the M spike or the monoclonal spike. So how do we screen for them? The photo I showed you here for electrophoresis, the M spike has to be of a certain value to be able to be seen. So it's not the most sensitive test. It's still a very important test to quantify the monoclonal protein. So obviously, you will need to do a serum and urine protein electrophoresis. But you will miss a lot of patients, especially the one presenting with neurological complications. As you know, in paraneoplastic disorder, usually the tumor is so small when it's causing immune trouble. And therefore, your test should be complemented by additional testing, such as serum and urine protein immunofixation. And the third test that's quite helpful and probably people are less familiar with is also serum free light chains and free light chain ratios. And I'll show you how. This is a busy table, but we're just going to focus on this line on the monoclonal gammopathy of uncertain significance. And these are the patients that present to our clinic. For a monoclonal protein to be called of uncertain significance, obviously there has to be no underlying hematological disease and has to be a lower certain level. But if you only do electrophoresis, as you see here, serum protein electrophoresis, the sensitivity is in the lower 80s. While if you do all your serum tests, serum and urine tests, so that would be electrophoresis, immunofixation, and free light chain, you will be able to detect all the monoclonal protein. But as you know, to collect urine for 24 hours is not easy, or it can be a hassle. So what if you only do serum tests? That's okay too, because if you do serum protein electrophoresis and immunofixation and the free light chain, you're about 97% sensitive. And then if the free light chain ratio is abnormal, that tells you there is something wrong. It does not have to be monoclonal. It can be polyclonal, for instance, patient with kidney failure. Then you can follow it up with urine studies. Or in patient where you're suspecting amyloidosis, you will need to do urine studies. Or if you have, like in any other scenario, you have very high clinical suspicion, you could still add the urine there and get to your 100%. Without going to details, a more novel technique that now we're using at Mayo Clinic as the standard test is to detect these monoclonal protein by mass spectrometry. But for the sake of time, I will not get into that. And as you know, monoclonal protein can have various combinations of heavy and light chain. For unknown reasons, you almost never see a monoclonal protein of the IgE or IgD subtypes. That will leave us with IgG, IgA, IgM, and of course, kappa or lambda. From neurological perspective and hematologic perspective, it would be more practical to group them into three groups. You have the IgM, you have the non-IgM, so IgG or IgA, and you have the light chain only. So people can have a monoclonal protein that's only light chain, to keep that in mind. Why do we group them in such a pattern? Because they have a different association with hematologic disorder. So the IgM monoclonal protein, if it is associated to a hematologic disease, that would be a lymphoplasmacytic lymphoma, or also known as Waldenstrom macroglobulinemia. While the myelomas are almost never IgM, like Poems syndrome, which is a form of myeloma, it's more than 97, 98% IgG or IgA. Light chain onlys behave like myeloma, but they have the lowest risk of progression, and they are the most common type in amyloidosis. We also classify them this way because they have a different rate of progression into hematologic malignancy, with IgM being the highest risk and light chain only being the lowest risk, but we're not going to get into that today as well. Just keep in mind that any type of monoclonal protein, heavy or light chain, can cause amyloidosis. So now you have a patient with a peripheral neuropathy and you find a monoclonal protein on testing. So how do you know? In patients older than 50 years, about 5 to 10% have peripheral neuropathy, and also about 5 to 10% have a monoclonal protein. So just by coincidence, the most common scenario is that you'll have patients where the monoclonal protein and the peripheral neuropathy is just coincidental, rather than one causing the other. So how can you tell that? A rule of thumb that will almost never fail you, and a question that I ask myself every time I see such patients, is the following. How different is the patient's clinical presentation or laboratory finding from an idiopathic peripheral neuropathy? If it sounds like an idiopathic neuropathy, looks like an idiopathic neuropathy, on EMG has no red flags, then it's most likely just an idiopathic neuropathy or neuropathy of alternative cause, and the monoclonal protein is coincidental. So to our audience who do general neurology, what does an idiopathic peripheral neuropathy look like? Which is the most common type of neuropathy. It's always length dependent, sensory predominant, and it's axonal on EMG. What do we mean by that? So patients mostly present with sensory symptoms, usually at onset more small fiber modalities such as tingling and loss of pinprick sensation. And later on, they develop large fiber modalities such as loss of proprioception and imbalance. Motor symptoms are not common. At advanced stages, you can have some toe weakness, but you should not have ankle weakness in an idiopathic neuropathy, or at least you should be careful if you have that. And it's very, very slowly progressive over the years. The lack of any of these characteristics should be considered as a red flag that requires further investigation. And that same rule applies to the paraproteinemic neuropathy. So let's start with an example from the first category, which is the IgM monoclonal gammopathies. Here's probably your most classic scenario. A 70-year-old man presented with a 1-year history of bilateral foot numbness and tingling. So far, nothing unusual. Lately, he has become markedly unstable, necessitating the use of Shacain. Well, that's very unusual for an idiopathic neuropathy in 1 year to have him lose his balance. No weakness, no autonomic, no systemic symptoms, so no other red flag. It's just that rapid progression and ataxia. On examination, he had pan-modality sensory loss with moderately to severely decreased joint position. He had no weakness, and he had a wide-based gait. So now you did your routine blood screen, and you find the monoclonal protein. You only saw it on immunofixation, so it's quite small, and it's of the IgM kappa subtype with mildly increased kappa light chains. The rest were all normal. In particular, there was no hypercalcemia, no renal failure, no other cytopenias. So as every patient with neuropathy, we would like also to characterize it from electrodiagnostic standpoint. And without bothering you with details, the column that we'll focus on here is the distal latencies, and particularly for the motor responses. And you can see that all the distal latencies are prolonged. There were no conduction block, no temporal dispersion, just what's called distal demyelination. So the neuropathy will tell you that's a neuropathy with a demyelinating feature. So it's not just an idiopathic neuropathy. It will not tell you what's causing it. So what would you do next? Would you do MAG antibodies? You could. They're only positive in about 50% of patients with IgM neuropathy. They're not associated with any different phenotype, any different response to treatment. They can also be seen in patients with a monoclonal protein without a neuropathy. So it depends on your practice whether you use them or not. Would you do a VEGF level vascular endothelial growth factor if you're thinking of POMS or a skeletal survey? Again, that's what I showed you, that the IgM are very rarely a myeloma. So you don't have to. You could if you have high clinical suspicion, but you don't have to. And a fat aspirate, well, everything can be amyloidosis. With the demyelinating feature here, the lack of any autonomic symptoms, the suspicion is very low. It's not wrong to do it and something easy to do, but also you don't have to. So walking through our algorithmic approach, and this was published in Continuum in 2020. So you have an IgM, systemic symptoms, anemia, thrombocytopenia, or high IgM levels. All of these are suspicious for underlying hematologic malignancy, and in particular, Waldenström macroglobulinemia. Our patient did not have these. IgM is the only monoclonal protein that can directly cause a neuropathy or an immune-mediated neuropathy, and therefore it requires further investigation. If the patient has sensory ataxia, demyelinating feature on EMG, with or without MAG antibodies, which is yes, then you're mostly suspicious for an IgM neuropathy. If not, nothing really unusual. It's probably coincidental and you would just observe. So in this case, the diagnosis of IgM-associated peripheral neuropathy, or DADS, distal acquired demyelinating symmetric neuropathy, was established. Very briefly here about treatment, because if the patient has underlying hematologic malignancy or amyloidosis, the treatment will be guided by the hematologist. But if they have an IgM neuropathy, the monoclonal protein would not require treatment from hematologic perspective, and you as a neurologist will decide on that. Briefly, there is no evidence that immunotherapy works. So just anecdotal evidence, and you can decide on a case-by-case basis whether to use rituximab. Usually patients with short disease duration, rapid progression, significant weakness, they're usually eligible for a trial. We didn't go into the different phenotype, but there's a group of IgM neuropathy that present just like CIDP with diffuse weakness, and would be quite difficult to say why this is not CIDP. So in those patients, we usually also try IVIG first, and then if they are treatment refractory, we may consider rituximab. But again, this is all anecdotal. If you go evidence-based, they do not respond, except the CIDP phenotype. All right, so that was the IgM. Now, what about the non-IgM monoclonal protein? So here's another example. 39-year-old man, 3 months prior to presentation, started having swelling in his feet and weakness. The weakness progressed and to include proximal and distal muscle, just like CIDP. And sensory loss ascended to his breathing. Here is an unusual, so for sure it's not an idiopathic neuropathy. And he started using a walker, so it's a very dramatic neuropathy. He also had bouts of severe abdominal pain and reported erectile dysfunction. On examination, this is his arm. It's probably, I tell you, this is my uncle's arm. You would think there's nothing unusual for a Mediterranean person, but this guy is a Midwestern of a Scandinavian origin, so this was very unusual for him. He had swelling in his feet, pitting edema, and white nail discoloration. He had lymph nodes, and the neurological exam is in keeping with his symptoms: hyporeflexia, diffuse weakness, and panmodality sensory loss. So you know you're dealing with a serious neuropathy. Common things being common, it could be CIDP, but we don't know that yet. So EMG showed an axonal and demyelinating neuropathy and with a very high CSF proteins. Now you did your usual workup, and on CBC, the patient has marked thrombocytosis. The serum protein electrophoresis again was normal, but immunofixation showed an IgG lambda. And here's a clue there. Every patient gets a complete blood cell count, and more than half of patients with POMS have thrombocytosis. So thrombocytosis really should be an alarm that should raise suspicion for a hematologic disorder in patients thought to have CIDP. And once you think of POEMS, polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, and skin changes, then you will order a VEGF. But if you didn't think of it, you may not order the test. And VEGF here was markedly elevated. We screened him for associated endocrinopathy that just looked like the normal population endocrinopathy. A skeletal survey, now you're suspecting form of myeloma, you do a skeletal survey. It showed 3 lesions that the radiologist thought they were non-specific, but because of the high suspicion, you still did your PET scan and found an FDG avid lesion. The diagnosis in his case was established on bone marrow biopsy as well, where he had a 20% plasma cells lambda restricted. So let's go through our algorithm again. So now we have a non-IgM monoclonal protein. Non-IgM monoclonal protein can be associated with myeloma. Here in this case, the light chain subtype is important because POEMS is almost always lambda. We're talking 99%. So if you have a kappa, it's less likely. You're mainly worried about multiple myeloma or, of course, amyloidosis. But multiple myeloma rarely causes these bizarre neuropathy. Multiple myeloma, if it causes something, it's usually compression of a nerve root by a bony lesion, or most commonly also chemotherapy-induced neuropathy. It's just a sensory neuropathy in general. There are exceptions that looks like your idiopathic neuropathy. And as screening with myeloma, you see if there are the CRAB, the acronym, which is hypercalcemia, renal failure, anemia, B symptoms, or other systemic symptoms. And if yes, you want to screen for that. Now, if you have the lambda, in addition to the possibility of being a multiple myeloma, it can be POEMS syndrome or osteosclerotic myeloma. So you're also going to screen for the features of POEMS. Thrombocytosis, organomegaly, skin changes like cherry angiomas, white nail discoloration, hypertrichosis, papilledema or edema anywhere, or of course, a rapidly progressive or demyelinating neuropathy. And these will prompt screening for POEMS syndrome. And it can be amyloidosis, definitely, but usually it's not demyelinating. So that's our non-IgM group. And now last about our light chain only, just a few things to say there. Sorry, before that. So POEMS syndrome, the treatment is dictated by hematology. Usually if they have up to 3 bone lesions, they might try radiation therapy, and that can be curable. If they have more than 3 lesions or bone marrow involvement, they get systemic chemotherapy. So light chain only, which is the last part. So first of all, yes, light chain only monoclonal protein do exist. They are the least common type of monoclonal protein and also have the lowest risk of progression into a hematologic malignancy. But if you take the patient with amyloidosis, the most common monoclonal protein in amyloidosis is light chain only monoclonal protein. And that's why doing the urine studies in these patients is of high importance. So for the sake of time, very briefly about amyloid neuropathy, the most common presentation, although people think of small fiber, is not small fiber neuropathy. It's a rapidly progressive neuropathy. 2/3 of patients at presentation are not eligible for a transplant. The most common presentation is a severe diffuse neuropathy, sensory, motor, generalized autonomic failure with severe pain. But less common presentation do exist, such as a painless form of that, autonomic failure, small fiber and autonomic failure, which is the least common. If you just somatic sensory small fiber neuropathy alone and the patient had it for a while, that would be very unlikely for it to be amyloid neuropathy. As we are out of time, I want to say that monoclonal protein are common in the general population. So if someone has amyloid and a monoclonal protein, it does not have to be AL amyloid. You still have to subtype your amyloid and make sure it's not transthyretin hereditary amyloidosis that require a different diagnosis. You try first to biopsy a surrogate organ, such as bone marrow, fat, skin, because of course they're less invasive. And if these do not establish the diagnosis, you need a target tissue biopsy, such as a nerve or a muscle biopsy. And with that, we complete our diagnostic algorithm with the light chain only. You're screening mainly for signs of myeloma or amyloidosis. And if these are not present, again, it's likely coincidental and you monitor them depending on the risk of progression. With that, I conclude my talk. This is actually from a muscle biopsy. A wave of regenerating fiber was also another sign of hope, and I'll be happy to take any questions or comments. And if we run out of time, feel free to contact me. This is my email and my Twitter handle, and thank you.
Thank you very much, Dr. Naddaf. There is one question. Do you ever see amyloidosis, neuro or other system involved in MGUS?
So to call the protein monoclonal gammopathy of uncertain significance, that means there is no amyloidosis there. But if it's just a monoclonal protein, you did the workup and it's amyloidosis, it's very commonly multi-organ involvement. I'm sorry, I skipped that statement there. The particular other non-neurological scenario that are highly suspicious for amyloidosis are a nephrotic range proteinuria, heart failure with preserved ejection fraction, unexplained hepatomegaly or diarrhea are particularly suspicious. So yes, it is usually a multi-organ involvement.
Thanks. So how do you collaborate with hematologists? Would you send patients very soon when you just find monoclonal antibodies, or do you have regular meetings with hematologists together?
We commonly have these patients evaluated by hematology. What do they help with? Even if it's a monoclonal gammopathy of uncertain significance, they rule out a hematologic disorder and they put a monitoring plan for this monoclonal protein. We didn't get into these details today. So basically, every patient with a monoclonal protein would benefit from being seen in hematology. The second one, the more challenging one, patient with IgM neuropathy from neurologic perspective and on EMG can look the same as Waldenström macroglobulinemia. So you could just be having an underlying lymphoma that you didn't detect. So that's why the practice of hematologists vary. In our hematologists, they get a bone marrow biopsy on all of these patients rather than triaging them who do they think has a high IgM or not. So yeah, I would say hematologists are a very valuable member of a multidisciplinary team to take care of these patients, and we work in coordination with them.
Another question, specific one. What's the reason for nerve conduction slowing in TTR amyloidosis?
Well, that's a very good question. TTR amyloidosis should not have nerve conduction slowing, and neither AL amyloidosis, it's usually axonal. The slowing that gets misinterpreted as demyelination is slowing of the conduction velocities due to the dropout of the fastest conducting fiber. So mild slowing, not within the demyelination range, so less than 30% of normal. For instance, in the lower limb, conduction velocity of 35 meters per second, 38 meters per second, this is not demyelinating. It's still due to axonal loss. But a demyelinating neuropathy, you should not have a demyelinating neuropathy in any type of amyloidosis.
Thanks. And there's another question. Okay, how often do you schedule follow-up for patients with MGUS?
So from hematologic standpoint, yeah. So that I didn't get into this detail. That depends on the risk of progression. So the ones that require close monitoring are the IgM ones. Any type of monoclonal protein, you recheck on them in 6 months. And at 6 months, if the protein is still the same level, let's say it's still only on immunofixation, or if it's detectable on electrophoresis, the spike hasn't changed, from there you can do it on a yearly basis. Now you could argue, and it's not wrong, some people, if they are low risk, so they're not IgM, they are below a certain level, some people argue maybe you should not continue to follow up on it. But because it's not 100% clear, I would say at least here, most of the patients get a yearly checkup. So first time in a 6 months, if it's of uncertain significance, and then from there forward, it's every year. Mm-hmm. And you just can repeat the protein electrophoresis and the free light chains, and just to see if there is any end organ like a CBC. You don't have to always keep repeating the immunofixation, for instance, because you know the protein is there. You just want to make sure it doesn't go above a certain average.
Okay, thanks a lot. Thank you for joining us in Ljubljana. Hopefully live next time, yeah?
Hopefully.
Yeah.